Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. We're continuing with the Blue Book today. We're going to be talking about endometriosis. The endometrium is the inner lining of the uterus, and we're going to talk about it when that inner lining somehow grows other places than where it's supposed to grow. That's endometriosis. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon again here with Clinic Reviews. We're going to continue on with the Blue Book. I talked last time I did a Blue Book lecture. I did menstruation in the ovarian cycle, and we talked about the endometrium. So I decided to follow up with endometriosis. The endometrium is that inner lining of the uterine wall. It grows and gets thicker. Well, it sloughs off at the beginning of the menstrual cycle or the ovarian cycle. And then it grows and gets thicker in response to estrogen. Once it's thick enough that can handle implantation, we see the egg is released and ovulation occurs. And then kind of the cycle goes back again if no implantation occurs. So we're going to talk about a disease of the endometrium, which is called endometriosis. As you know, this channel is a part of the Greater Clinic Review organization. We do the very best NCLEX reviews in the entire universe, in my opinion. You can find them on demand online if you go to clinicreviews.com. Mark Klimek, the GOAT himself, teaches those. It's very good. It's multiple lectures, 30 some lectures. It includes questions. It includes the yellow book. It's really good. We also offer a small group tutoring package that you can purchase. It's a month of small group tutoring, and they're also recorded, and you can watch them again after the fact, and you can even purchase just the recordings. I think you can do that. So we also have a streaming service, which is all the videos here on YouTube, plus some additional videos that you can watch with no commercials. It's under $20 a month to have access to every single one of those videos. Okay. Let's go ahead and get started with endometriosis. Remember, the endometrium is the inner lining of the uterine wall. Which of the following is the primary pathophysiological feature of endometriosis? Endometrial tissue forms polyps in the uterus. Endometrial tissue grows outside the uterine cavity. Uterine tissue becomes hypertrophic due to inflammation. Scar tissue replaces the endometrial lining. And the correct answer is either you know it or you don't know it. The endometrial tissue grows outside the uterine cavity. Y'all, if we knew why that happened, we'd all be rich and we could solve this problem and we'd have no more endometriosis. So I don't know why it happens. For some reason, endometrial tissue migrates outside of the uterus, attaches to other places in the abdominal cavity, and it causes problems. And just like the endometrial lining in the uterus, it grows in response to estrogen, and then it kind of stays thick for a few days, 2 weeks, while it's waiting for implantation. If no implantation occurs, it sloughs off and causes bleeding. And that's the problem with endometriosis. Imagine having endometrial cells somewhere else, attached to the kidneys, attached to the ovaries, attached to the bladder. It can cause a lot of pain, particularly when you're seeing that sloughing and bleeding somewhere else other than in the uterus. And it can also cause, kind of over time, it can cause scar tissue to form and some problems to occur. It's interesting. This is the same thing that happens with metastasized kidney cancer. Endometriosis is not cancer, y'all. Cancer is when you have cells that multiply, and as they multiply, they become less differentiated. Less differentiated means they look less and less like kidney cells. So if kidney cancer metastasizes somewhere else, it grows, but it also looks less and less like kidney cells. And that's what the difference is between like endometriosis and endometrial cancer that's metastasized, right? The endometrial tissue, if it's cancer and metastasizes, it looks less and less like endometrial tissue over time. But the interesting thing about kidney cancer that metastasizes is that it continues to filter drugs. So this is totally off the subject, y'all. This is why kidney cancer is so difficult to treat with chemotherapy, because the kidneys filter all these drugs. And so you try to treat kidney cancer with chemotherapy, and no matter where that kidney cell is, it filters that drug and it doesn't help, which is why kidney cancer is difficult to treat other than through surgical removal, radiation. I think there's some experimental treatments out there going on, but it's challenging to treat kidney cancer. A client with suspected endometriosis asks what diagnostic tests are commonly used, which test is considered the gold standard for diagnosing endometriosis: MRI scan, pelvic ultrasound, laparoscopy, pap smear. The gold standard is actually laparoscopy. A laparoscopy goes into the abdominal cavity and looks around with a camera. That's what a laparoscopy is. You actually have an incision in your abdomen, and you have a couple other incisions so that they can cut anything out that they need to, but you have a scope going in and they're looking around, and that's what they're doing. They're looking for endometrial cells. It doesn't sound like something easy to do. It sounds like they'd have to really know what they're looking for in order to be able to identify it. If you don't know this, when they do a laparoscopy, they actually insert air into the abdominal cavity and it blows the abdomen up so they have more room to look. And that's why the person feels so bloated when they come out of procedure after laparoscopy. Which symptom is most commonly associated with endometriosis? Dysmenorrhea, painful bowel movements, fatigue, or hot flashes? The correct answer, which you probably can guess, is dysmenorrhea, painful menses. And so when you have bleeding other places other than just the uterus, it can cause a lot of abdominal pain. So dysmenorrhea means pain with menstruation. And so that bleeding is occurring other places than, it hurts enough as it is, right? Normally, because you've got the contracting uterus and it's contracting and having some issues and causing pain. But then you have that in addition to bleeding in other parts of the pelvis. And yeah, that's painful. When educating a client about the use of tampons during menstruation with endometriosis, the nurse should emphasize what? Tampons should not be used as they increase the risk of endometrial tissue spread. Tampons are safe to use with endometriosis if changed frequently. Tampons may increase the risk of pelvic infection and should be avoided. There's no difference in using tampons or pads for endometriosis management. So there is a difference between tampons and pads. Tampons are absolutely contraindicated with endometriosis, but endometriosis is not the kind of thing that you can spread. You don't spread it by the use of tampons. It just increases the risk of pelvic infection. Honestly, y'all, I don't know why. That's not intuitive to me to know why that is. I'm just telling you, it's a fact that you need to teach your patients. If you want to know why that is, go ahead and Google it. I don't know. I didn't Google it ahead of time, so I don't know exactly why that is. The nurse is teaching a client with endometriosis about hormonal therapy. Which medication used to manage endometriosis is an androgen derivative? So remember, the endometrial lining grows in response to estrogen. Okay, so if we can suppress estrogen, we can reduce the growth of that. So yes, it does impact fertility, but it's also going to reduce the pain associated with endometriosis. So androgen, you should know the word androgen. It's a male sex hormone, essentially. Androgens are male sex hormones. And there's a lot of different male sex hormones. Testosterone is one of those, but testosterone is not the androgen that we're going to give, okay? So if we were to guess here, estrogen is a female sex hormone, so we don't want to give that. It's actually going to stimulate the growth of the endometrial lining. Progesterone is a female sex hormone. It may not promote the growth of endometrial lining, but it's certainly not going to inhibit it. Clomiphene is actually used to treat infertility, so that's not an androgen. Danazol is the only one here that's an androgen. So do you need to know what all the others are for? Well, you certainly should know estrogen and progesterone are female sex hormones, and they're not androgens. Clomiphene, whether you know what that is or not, it's probably not necessary for you to know that. But danazol is the treatment of choice for endometriosis. It is a male sex hormone. It suppresses estrogen. So if you think about suppressing female sex hormones, what are the things that result from female sex hormones? Well, female sex hormones promote fertility. They increase the pitch of the voice. They somewhat prevent acne. So when you give someone an androgen, which is also considered a steroid, by the way, male sex hormones are what are used to promote muscle growth when people are weightlifting or in sports, and they're not legal most of the time because you have an advantage over everybody else if you're using male sex hormones, right? So you could have increased muscle mass if you're taking an androgen. So if you think about what are the side effects of danazol, should think, don't memorize them, but think, what are male typical characteristic male traits that I would expect to see from a male sex hormone. A client with endometriosis asks how menopause might affect her condition. The nurse should explain. So with menopause, you no longer have ovulation, and as a result, you don't secrete progesterone as much. So you have a decrease in progesterone, and you also will see a drop in estrogen. So one of the things that leads to menopause, one of the things that takes women into menopause or premenopause is they start to have decreased levels of estrogen and other female sex hormones. So if you have decreased estrogen as a result of menopause, well, what's going to happen to the endometrial lining? You're not going to have much. It's not going to grow and slough off and grow and slough off every month. Okay. So think about that. So what happens with menopause? Symptoms may worsen. Well, that doesn't make sense. Endometriosis symptoms typically improve after menopause. That's true. Menopause has no effect on endometriosis. That's not true. Endometriosis is cured with menopause. So it's not cured. I wouldn't say it's cured because the person still technically has the diagnosis of endometriosis. What they don't have is they don't have the symptoms of endometriosis. So they may still have endometrial cells other places in their pelvis. They're just not having any symptoms because they're not growing and bleeding, right? So that's why endometriosis symptoms improve after menopause. What is the primary action of danazol in the treatment of endometriosis? Well, here we go. It suppresses the hypothalamic pituitary ovarian axis to decrease estrogen production. Well, that's a complicated answer. I know it decreases estrogen production, and it makes sense to me that it would be a hypothalamic pituitary ovarian axis. So I'm keeping that on the list. It promotes estrogen production. Absolutely not, because if you had increased estrogen production, you'd have worse endometriosis. It enhances progesterone activity to prevent ovulation. No, it doesn't. Androgens don't increase female sex hormones. It stimulates the endometrium to heal. No, it doesn't do that. So it just decreases estrogen production. That's what it does. A client is prescribed danazol for endometriosis management. Which of the following side effects should the nurse teach the client to report? So it's an androgen, which means you're going to look for stereotypical signs of male traits, masculine traits that you would expect. Weight loss. Yeah, I wish. Deepening of the voice. That's a characteristic male sex trait. Excessive menstrual bleeding, not an stereotypical masculine trait. Sudden headaches. I mean, you might get headaches. Any medication can cause headaches, but it's not sudden is the word that makes me think not, because you really shouldn't have sudden headaches. Headaches can result from just about anything, but sudden headaches makes me think no. So deepening of the voice is the characteristic male trait there that I would pick. A client with endometriosis has been experiencing dyspareunia. What does the nurse identify as the likely cause of this symptom? So before I read the answers, I need to know what this is talking about. So endometriosis, I say, well, they have endometriosis and now they're having dyspareunia. Don't know if I'm saying that right. That is painful intercourse. Okay, so you should know DYS is something painful or abnormal, right? If you didn't know what periunia is, you should know it. It's intercourse. So they're having painful intercourse. So I think, well, they specifically told me they have endometriosis. So I need to pay attention. So which one of these is most likely associated with the endometriosis? Inflammation of the fallopian tubes. I mean, they could have inflammation of the fallopian tubes, I suppose, but that doesn't seem like that would be the cause of painful intercourse. Low estrogen levels, no. Hormonal imbalance, no. Scar tissue adhesions in the pelvic area. That makes more sense. Out of all of these, even if I don't know that scar tissue and adhesions in the pelvic area can occur because of endometriosis, it's the only one that makes sense because I know none of the others make sense with endometriosis. And A, which could happen with endometriosis, I suppose, doesn't make sense to cause painful intercourse. So, and D, scar tissue and adhesions in the pelvic area is one of the reasons why infertility is a high risk for people with endometriosis. What is the effect of androgenic medications like danazol on the menstrual cycle of clients with endometriosis? It induces ovulation, no. It induces amenorrhea. It seems like it could, because if you lower estrogen levels, estrogen is one of the things that stimulates the ovarian cycle. It seems like it could cause amenorrhea. It increases progesterone levels. No. It stimulates regular menstruation. No, absolutely not. So the only one that makes any sense is that it could cause or induce amenorrhea. The nurse understands that endometriosis is primarily influenced by which of the following hormones: progesterone, androgens, estrogen, or thyroxine. I hope you know by now, after all the things we've talked about, that it's primarily influenced by estrogen. A 27-year-old female diagnosed with endometriosis expresses a desire to become a mother. Which of the following is the best nursing response? Endometriosis usually causes infertility. Well, that's true. Well, maybe not usually. It often does. Maybe not usually. Do not postpone pregnancy, as infertility is a complication of endometriosis. So I like that wording better. I don't want to say usually, because I wouldn't say usually, but it is a complication. And if she's saying I want to be a mother, I would be more likely to say, well, don't wait, because this is a possible complication. And that's because of the scarring and all that stuff that can occur because of it. So I like B better than A. You should wait to attempt pregnancy until after treatment. Actually, that's not true. You should use birth control until you're ready to become pregnant. Maybe, but that's not related to endometriosis. We're specifically teaching her that infertility is a complication of endometriosis. So you probably don't want to wait too long before you try to get pregnant. All righty. Well, that's it. I hope that was helpful to you. And if you watched menstruation and the ovarian cycle, these two videos really go together and complement each other to help you remember some of the hormones and so forth that are going on during the ovarian cycle. So I hope it was helpful to you and you better understand endometriosis. Love you guys. See you later. Have a great day.